All right, Rachel, take it away.
All right. Well, good evening, everyone. Welcome to our 38th virtual shadowing session, Forensic Medicine. So sorry we had to cancel our last week's session. Texas had rolling outages and several of us had, no power, no water. So we are really appreciative of you guys sending, warm wishes and kind thoughts during this time. And we will be rescheduling that session. So stay tuned. If you have any questions regarding our program, please contact us through our Instagram at virtual shadowing or email us at virtualshadowing@gmail.com. As always, these sessions will be recorded and posted on our YouTube channel, Pre-Health Virtual Shadowing, right after. Next slide, please. These sessions are brought by our wonderful working group comprised of Reagan, Shayon, Taylor, Elena, myself, Rachel, Anirudh, Miriam, Rohit, and our 4 physicians, Dr. Fowler, Dr. Marchetti, Dr. Salazar, and Dr. Reno. Now, Dr. Salazar has a quick announcement about VCOP. Dr. Salazar?
Hey guys, good evening. Good to see you all. Thank you all for your very kind wishes last week. It was rough, but we made it through. We wanted to announce, well, you guys asked us for more virtual shadowing opportunities. Well, we got you VCOP. You guys wanted some podcasts, so now we got you a podcast, okay? So remember, our second episode for VCOP is happening next Thursday at 7 p.m. CST. Registration, I'll put it here on the chat. And remember, registration, all that stuff is right there on the website. And then the VCOP podcast is going to include everything from pre-health advice, finances, special guests, all that wonderful stuff that's going to be coming in the spring. So we hear you. We got your advice and we're really excited. Hit me up on Instagram if you have any questions. Thank you.
Perfect. Thank you. And if you guys have any questions about VCOP, we do send out information about VCOP through our email every Wednesday and Sunday. And we also have information posted on our website. So next slide, please. Our upcoming sessions are super exciting as well. Next week, we have a PA spotlight in critical care and finance. The following week is a PA spotlight in family medicine and lifestyle. And then the week after that, we will have a specialty spotlight in plastic surgery. If you want to see the complete schedule for March, stay tuned on our Instagram and our emails. All of those sessions will be on Zoom or YouTube Live at 7 p.m. Central Standard Time. Next slide, please. If you have any questions for our provider, Dr. Hale, put it in the chat. The team and I will be collecting these questions and giving them to Dr. Hale during our 2 designated Q&A sections, one in the middle and one at the very end. If you have questions regarding the assessment, we will talk about that at the very end after the last Q&A. And as always, these sessions last about an hour and a half to 2 hours. Without further ado, can Dr. Fowler introduce our wonderful speaker for tonight?
Well, hello, everybody. It's so good to have you. What a difficult time this last week or so we've had. We apologize for our very first loss of a session this past Tuesday. We literally did not have power and our laptops were not charged, so we just had to cancel the session. So sorry for that, but we're going to keep on keeping on. And as long as you keep coming back, we're going to keep coming. Yesterday, we reached over 45,000 people who have signed up on our website. So there clearly is a momentum to be involved with virtual activities. I believe personally and professionally that what's going to happen with COVID finally beginning to go away or ease off is that we've discovered a new trend in virtual activities. And as a member of an admissions committee activity, I'm on the admissions at Southwestern. I think that it's just my opinion that I think virtual activities will keep on keeping on. So I would say stay tuned. We've been trying to decide what to do about moving forward beyond this coming summer. And so at the moment, we're going to keep on doing virtual shadowing. But we would love to get some feedback from you if you find that this remains a useful activity for you in your long-term plans. Okay. Ladies and gentlemen, I want to introduce to you tonight one of my favorite people in the entire universe, Stacey Hale. I met Stacey almost 20 years ago. Stacey and I have one thing in common, which is that we both have a ring that looks like this, which is the class ring from the Medical College of Georgia in Augusta, Georgia, where I graduated back in the 70s, and Stacey graduated a little bit later than that. And Stacey came to be in our emergency medicine residency back a little before 2000. I think, Stacey, I believe you were in the third emergency medicine residency program with us, and I got to know Stacey up close and personal, taking care of thousands of patients together. Stacey went on after emergency medicine to do a fellowship in toxicology, specializing in those things that are chemicals and are poisons, and went on then to develop a career in becoming a consultant on legal activities as regards forensic medicine. And tonight you're going to find this, if you've ever been a groupie on forensic files or Law and Order and so forth, you're going to find tonight absolutely fascinating. Ladies and gentlemen, I'll be quiet. I want to present to you someone who I think is one of the finest intellects, one of the greatest doctors and smartest people I've ever known. Would you please join in welcoming me with Stacey Hale. Stacey, welcome. So good to have you.
Well, thanks, Dr. Fowler. And Dr. Fowler is correct. We go back in time. And some of my favorite memories of Dr. Fowler, besides coming to my home to celebrate emergency medicine gatherings and parties, he is a fantastic pianist. And I have a 1914 Steinway piano that was restored. And whenever he comes over to my house, it is very, very difficult to get him off that piano. And so I have some fabulous pictures of him and memories playing the piano with Dr. Fowler. And one of my favorite memories was a number of years back, I wrote a song for our graduation, and it was to Billy Joel's Piano Man, only it's called the ER Doc. And so I wrote the lyrics, I rewrote the lyrics to Piano Man, and it was Dr. Fowler on the piano and then one of the other residents on the harmonica, and I was the vocalist. I'm not a very good vocalist, but it was all for fun. And that is probably one of my favorite memories with Dr. Fowler, was pulling this song together for graduation. So anyway, yes, it's true that we do go way back, and I consider him a very special friend and also a mentor. And so it's a pleasure to meet you guys and to have all of these folks who are aspiring to go into medicine. This presentation is, I would like to say, more on the entertaining side than perhaps the learning side, but sometimes some of the best learning happens when you are, after all, entertained. So this is my family. I have a daughter. The oldest is Alexander, and he is 17. He is in 11th grade here in Highland Park. And then my daughter, Savannah, is in 9th grade. And my youngest son, his name is Austin, and he's in 6th grade. And then my husband is an attorney here in Dallas. He does business litigation. And as you will find out as I go through the presentation, I do work with attorneys quite often. And I suppose a lot of physicians are sometimes intimidated by lawyers, but I figured if I was going to be deposed every day, I might as well get paid for it. So it does help to be married to an attorney. So this was from this past Thanksgiving. And whenever people ask me about my children, they always are like, oh, you know, are your kids going to be doctors? Are they going to be lawyers? And the answer is, as far as what I can tell right now, no. My children are aspiring rock stars. And I don't mean that in jest. You can see in the upper left-hand corner here, Austin. This was from a virtual showcase. One of the casualties of COVID, which has not been just that we have to do all of these presentations virtually, is that a lot of the venues where people perform have shut down. And so my kids, they still have some showcases live, and typically those things would have been at House of Blues or Six Flags. They at different entertainment venues in the Dallas area, and Gas Monkey Live was a huge venue here in Dallas that hosted a lot of shows, and because of COVID, it actually went out of business for good. So that's pretty sad. But so this is Austin, and he was his head shop for the Septian Entertainment Group, their live showcase that they have once a month. And here he is in the Christmas showcase singing The Walker by Fitz and the Tantrums. And then Savannah at our last showcase doing Crazy, taking it old school back to Patsy Cline, and a little bit of Sia and Candy Cane Lane. And then my oldest son, Alexander, is probably more of the classical as far as his music. And so here he was playing Chopin's Fantasy Impromptu, and then also doing a vocal on the piano at a bar. So anyway, this question you might be able to get a question right on the assessment if you paid attention to this. So anyway, I also want to introduce my pets. We did have a snow apocalypse this past week, and so this is McKinley. She's a Bernese mountain dog. They're farm dogs from Switzerland, and they love the snow more than anything. So she was the one individual that was probably happiest during the last week. And then we have this fluff monster on the cat bed that I'm sitting on now because Dr. Fowler said I was too short for the camera. This is my Maine Coon cat, and her name is Sable. And then we recently rescued this black cat named Salem. So these are my pets. And the other day I walked upstairs and I found the two cats. Not sure what's going on here, but I caught them, I think, in the action playing ping pong. So I grew up in Roswell, Georgia, and I was the Roswell High School nerd. Throughout high school, I did cancer research, and every year I entered the science fair at my high school, and then I went on to my senior year, and I won the Georgia State Science Fair, and I went on to the International Science Fair. So this is a picture of me in high school in front of my science fair project and in the local newspaper. And I guess, you know, when you spend 4 years of high school doing science fair projects, it's great to get some scholarships into college, but sure guarantee you not to get a homecoming date. Then I went on to Southern Methodist University here in Dallas, where I received my Bachelor of Science in Chemistry, and that's 4 years. This is the famous Dallas Hall on the SMU campus. And then I had to show a picture of my mentor. This is Dr. Edward Beale. He is actually one of the chemists that invented Tylenol. And here he is with me when I graduated in 1995. And then I kept up with him throughout the years. And this was a few years ago. And then he recently died 1 year ago. But I show a picture because all of us here have probably gotten to where we are in life because of special mentors. And I can't stress enough how important it is to really find one person that you connect with professionally and personally to help guide you through this journey in medicine. It's so rewarding. Then I went on to the Medical College of Georgia in Augusta, Georgia, and Dr. Fowler was showing our class ring a couple minutes ago, but this is where I spent 4 years of my life. And then I went on to Parkland here in Dallas, where I did my internship and residency. And of course, whenever I bring up to anybody that I work at Parkland, their first thought is that Parkland is famous because this is where JFK was taken after he was shot. And I have some pictures here from the old Parkland, and I have a lot of nostalgia. This is what a trauma room looks like before a trauma comes in, and this is what a trauma room looks like after the trauma comes in. So this presentation that I'm going to give is going to be in 3 parts. The first part is just talking about emergency medicine, and then I'm going to talk about medical toxicology, and then I'm going to talk about some of my forensic cases that I've been involved in. So my emergency medicine training at Parkland was an internship that was 1 year, and my residency was 2 years. Some programs are 3. This is my residency graduating class standing on the roof of the ambulance bay at the old Parkland. And there are about 45,000 emergency physicians in the United States. This is our University of Texas Southwestern Department of Emergency Medicine. And you can see Dr. Fowler there on the front row. And I'm sure if I looked around, I could find Dr. Salazar in this picture. But the faculty of University of Texas Southwestern are the ones that staff the Parkland Hospital Emergency Department. And here I am in the old Trauma 1 at the old Parkland Hospital. This was on the last day that Parkland was open, the old Parkland that is, and I just had to grab a picture for the nostalgia because that was where I trained. And of course now we all work at the new Parkland Hospital, and this is a beautiful facility. I don't know if anyone has ever seen it, and I wish I could give you guys a tour at some point, but it's barely, I can barely get in the front door myself nowadays without getting my temperature checked and having to do a COVID pass, but this is the new Parkland Hospital. So the Parkland ER is, believe it or not, the single busiest ER in the United States. And I say single busiest because this is one emergency department, whereas there are some hospitals that have groupings of emergency departments that may as a group have more patients, but we have one every time that I've checked over the last few years. So when you're an emergency physician, you are the most famous person at a cocktail party. And so I have to always be ready to tell stories because everybody likes to hear stories. And so I've come prepared with some of my favorite anecdotes from the emergency department. So the first is the hand versus the wood chipper. And so these white things that you see are the tendons. And paramedics came and handed me this red bag. And I'm like, what's in this bag? And I opened it up and it was a hand salad. So they handed me the digits with the hopes that maybe our hand surgeons might be able to reimplant some of that. On this bottom, this mouth right here, the story behind this guy is that he was a cusser. And he cussed so much that his mother told him he needed to cut his tongue off. So he did. And I'll tell you what, a lacerated tongue bleeds like crazy. And so this is what it looked like after we just sutured back together what was left of his tongue. Over here, this is pus in the eyeball. And so this would be something that would happen from untreated conjunctivitis. And the actual term for this kind of infected eyeball is called endophthalmitis. Now this picture down here is what we would call a sagittal section of a CAT scan. And basically what this is a cross-section long ways of the head and face. And so up here in the skull, you can see the brain, and inside the brain, you see these two little cross sections of white dots. What are those white dots, you might ask? Well, they're golf pencils, of course. This was a golfer that was out on the golfing range, and I guess he was having a bad game, and he took those little golf pencils that you keep score with on the cart, and he shoved them up his nose. They fractured the cribriform plate, which are these bones at the back of your nose that go into your brain, and the golf pencils actually entered into his brain. This unfortunate lady was crossing Harry Hines to the old Parkland Hospital when she was hit by a car, and she was thrown up into the air and then came down on the back fin of the car and had a near decapitation. So when she came in as a trauma patient, this whole area of her neck was exposed. And the rule always is to get an airway first in emergency medicine. And I was unable to put the tube down her mouth from where her face was because everything was very unrecognizable. But because she already had this large laceration in her neck, I was able to put this endotracheal tube right into her trachea. And then she also sustained an open tib-fib fracture from this accident. Unfortunately, she did not survive this motor pedestrian collision. Sometimes simple problems, simple fixes in the emergency department. On the left side of the screen is a lady, and she was so cute. She came in, she was elderly, and she was complaining about not being able to hear. So I took the otoscope and I looked inside her ear canal as part of the physical exam, and I couldn't even put the otoscope inside of her ear because there was a huge wax impaction. So the medical term for earwax is cerumen, and so this is called a cerumen impaction. And this cerumen impaction actually came outside of her ear canal and was visible just looking at her ear. So I grabbed some forceps and I loosened it up a bit, and it came out pretty much in one piece. And once I got all of that out, she looked at me and she threw her arms around me and she said, "Praise Jesus, I can hear again." And it was just one of those sweet moments in emergency medicine where you realize that sometimes there are simple fixes to problems that can make a huge difference in somebody's life. Now, over here on the right, this is for those of you who have felt so inclined to stick your finger in your gas tank. Don't do it, okay? So this lady was at a gas station and she stuck her finger into the gas tank. Well, you've probably noticed that there is a piece of metal flap that covers the tank itself. And so when you insert the hose into the gas tank, it pushes that metal aside. So she stuck her finger in it, and that piece of metal came smack down on her finger. And every time she tried to pull it off, it was about to cut her whole finger off. So the EMS was called, and they were unable to get her finger out. So they had to dismantle the car. They had to use a special soldering device to solder the gas tank because they didn't want to ignite the gasoline. And they had to bring her in, gas line and all, into the emergency department for us to remove her finger. And I'll tell you what, no one in medical school prepares you how to remove a finger out of a gas tank. And it's the only time I've ever seen that, and I've never seen it since, but these are the kinds of things you have to be prepared for. And sure enough, I mean, every time you pulled on that finger, it was cutting the finger. So basically what was done was that metal flap that came down had to be fatigued after a while until it broke off. And then her finger was able to come out. In the ER, we see a lot of people that swallow foreign objects. So this person over here swallowed a razor type of device and some forks. This person swallowed a crucifix. We have a bunch of nails over here and a spoon. And then sometimes in the ER, you see foreign objects that are not swallowed. And this is a bottle of Lee & Perrins Worcestershire sauce. Here is a picture of
Stacey, I have to ask you, did that bottle need warming or something? Is that why it was where it was?
I'm not going to answer that, Dr. Fowler. All right. So in the ER, there are sometimes people that come in high, and this was a patient that came into our new Parkland, and they were high on meth, and they jumped through the ceiling tiles, and they crawled out of the room and down the hallway, where they came crashing through the ceiling at the nurse's station. This was actually a case I had the other day. And this poor lady had not been seen in her apartment complex for a couple weeks, and she had no family or friends. So no one really noticed that she was missing. So, or that she hadn't come out. And so her landlord called the police for a wellness check, and they had to bust down the door to her apartment. And when they went in, she was found in pretty poor condition. This was a big neck mass. And because of this neck mass, which apparently grew rather rapidly over the period of a couple weeks, she was unable to eat or drink anything. And her airway she was not able to breathe unless she was in a certain position. So this ended up being an airway nightmare for us. And she's laying on her side like that because that was the only position that she could actually get oxygen into her lungs. So it required us as emergency physicians and calling anesthesia and calling the ear, nose, and throat doctors to come down and try to secure her airway. And so just to show you how terrible this was, I've put a chest x-ray of a normal chest x-ray just taken off the internet. And I outlined in green what an airway should look like on a normal chest x-ray, nice and in the center of the chest. And on chest x-rays, the air, of course, looks black. So you can see in between those green lines where the black is, and that's the trachea. That's where it should be. But on her, and this is her chest x-ray, I've outlined in red where her airway actually was. And you can see between the red lines, this black area, that is her trachea. And so it's gone way off to the side and curved its way down. So the yellow line is where it should be, the red is where it was. And so as a result, being able to put a tube in for her to have an airway was next to impossible. And it took about 2 hours with 3 anesthesia attendings and the chief of ENT guiding their way fiber optically to secure her airway. This ended up being an inoperable thyroid cancer that, like I said, grew up super duper fast. And she did not live through this. Sometimes there are things that come into the ER and we don't know what they are. And this is no exception. This was a teenage girl that came in, and her request was for me to remove this mass. And of course, you can see that it's pedunculated, it's on a stalk. And there was a lot of blood supply going into this mass. And so if your thought was, oh, I'm just going to cut it off, it likely went into her skull and had a lot of blood supply. So this would require something more than just cutting it off. For all of you folks that have friends that do cheer, this is when cheer goes wrong and you come down on your foot inappropriately on the mat. And this is a very severe fractured ankle. And of course, we've all heard about COVID, and I wanted to just show what the difference is. Again, I have a normal chest x-ray from just off the internet. This was a young guy, he was in his 20s, who came in with early symptoms of COVID. And so you can see where these little white patches around the lungs exist. And that's early. But then towards the end of COVID, where it becomes severe, you have almost complete whiteout of the lungs. So one of the questions I get a lot from a number of different folks is, what is the compensation for emergency physicians? And I pulled these stats a little while back, and I'm sure they've changed somewhat, but it's kind of hard to pin down a number because emergency physicians have a tendency to work as much or as little as they want. And it depends on whether you live in rural locations or whether you live in big cities. But the Southeast seems to have led the country for a while with about an average of $231 an hour or $406,000 a year, depending on how much you work. The reason why I think emergency medicine is a great choice for women is, there have been times, just depending on whether I was pregnant or having a new baby or, needing to have time to raise children. Emergency medicine is shift work. And so when you're going to work and when you're not going to work. And so I have tended to work part-time just so I have time for my family, but also time to do what else I'll be explaining in a little bit here. And here's an example of what a schedule will look like. This is one of our schedules, and I work 45 hours a month, and I generally make about $150,000 to $160,000 a year. So that's not bad for part-time work, especially since I work in the ER in a month about as much as what a lot of regular people do in a week. Now, after I finished my emergency medicine residency, I went and did a 2-year fellowship at the North Texas Poison Center, and this is called medical toxicology. So medical toxicology specializes in the management and treatment of poisoned patients. So this is 2 years after emergency medicine most of the time. And I get a lot of questions like, why is it that you're emergency medicine, but you're also medical toxicology? Like, isn't that like being in a lab or something? And the answer is no. Their medical toxicology are medical doctors that manage people that have been exposed to all kinds of toxins. And
hey, Stacey, are y'all all holding bottles of booze in that picture?
What we have in this picture, this is from our Poison Center Museum. And we have a bunch of antique medications in there. We like to collect those. So, and then over here, this is one of the former residents, and we're writing the chemical structure for Tylenol. So acetyl para-aminophenol, that's what that structure looks like. We also have a pet tarantula in the Poison Center. So whereas there are about 45,000 emergency physicians, there are actually only approximately 300 board certified medical toxicologists in the United States. And again, the reason why a lot of medical toxicologists are also emergency physicians is because you have to think about it. Where do overdoses show up? They don't go into the family practice office, they go into the ER. Where do chemical exposures happen? Where does If you're in a house fire and you have carbon monoxide poisoning or cyanide poisoning, where do you go? You go to the ER. If you've been bitten by a snake, where do you go? You go to the ER. And so we are specialists in acute medical toxicology, and we get consulted on all things poison. So overdoses on prescription drugs, overdoses on illicit drugs, any kind of chemical, snakes. This is a black widow spider. This is the feared blue-ringed octopus. So if there are, our colleagues in Australia have a lot of stories to tell of their exposures to sea creatures. We have to be knowledgeable about all kinds of poisonous plants, all kinds of poisonous mushrooms. We have to know about any kind of industrial or environmental incident, as well as chemical weapons. So this is what the fellowship in medical toxicology involves. You can see why it takes a couple of years, because there are poisons that range in so many different ways. So the first poison center was created in 1953, and there are approximately 63 in the United States. Each one has a medical director who is a medical toxicologist. And as part of medical toxicology, I do end up going on television quite often, educating the community about the latest drug craze. For example, this was at the old Parkland talking about the drug Flakka. This was on Al Jazeera talking about prescription heroin. And so I've talked about all kinds of, whether it's Four Loko or the Beeson Height, fentanyl epidemics. Part of our job as medical toxicologists is to keep the community knowledgeable about emerging drugs. So as a medical toxicologist, I have a couple cases to show you. This is a pediatric case that came into Children's Medical Center here in Dallas. And this was a 16-year-old. He was a healthy African-American male, and he presented to the ER with 4 days of chest pain that was described as severe pressure. So with increased pain, he also got very sweaty and he was short of breath. And an EKG and lab showed that he was having a heart attack. And so this is his EKG. And I have circled here where, I don't know if you guys have learned how to read EKGs yet, but this is called ST segment on the EKG, and it's an elevation. And this is having a heart attack. Well, I'm sure you're all thinking, wow, 16-year-olds shouldn't be having heart attacks, right? That's not something that we see very often. So once the parents were out of the room, he admitted to smoking K2. Now, K2 is also known as spice, and this is what we would call a synthetic cannabinoid. A synthetic cannabinoid is like marijuana, but instead of binding partially to the marijuana receptors in the brain, it actually binds completely to the receptors in the brain. And so we have a whole host of effects that are much different and, of course, much worse than what we see with regular marijuana. And there are about 155, probably more, compounds that are synthetic cannabinoids, and it's hard for us medical toxicologists to keep up with them. But in this particular situation, this healthy 16-year-old had a heart attack from smoking K2. Another case, this is a 14-year-old female, and she goes home from school with a girlfriend, and she becomes the worst house guest ever. So she's going crazy. She starts destroying stuff in the friend's house. So the friend's parents end up calling 911, and of course the girl's mother. So she's brought to Children's Medical Center Dallas, where she's so agitated that they had to sedate her, intubate her, and place her on a ventilator. So in the ICU, the mother hands us something she found in her daughter's backpack. And this is something that is called a blotter paper. So what is sold on blotter papers? Well, in the 1960s, LSD is what was sold on blotter papers. But even if you go on the dark web these days and order LSD, you're not going to get LSD anymore. what you're going to get is a substance called N-bomb. And N-bomb refers to chemicals that are 25I N-bomb, 25C N-bomb, and 25B N-bomb. Those are the main ones. And they were created for medical research. Now, they're similar in effect to LSD or ecstasy, and they sell for roughly $7 to $10 per hit. But these things are awful. They are sold on these blotter papers, so people think they're getting LSD, but they're not. And they create agitation like nothing you could have ever seen. People get really hyperthermic with temperatures 105, 106, 107. And there have been a number of deaths associated with N-bomb. Now, this particular patient ended up doing okay, but she did require being sedated and placed on a ventilator. So here's a case that I had at Parkland, and it's unclear to me whether this lady was having like suicidal ideation or if this was an accident, but she consumed this orthene fire ant killer, and it contains a type of insecticide called an organophosphate. Now, a lot of organophosphates have been banned, but if you've ever sprayed an insect, especially like a roach, with any kind of insecticide, have you ever noticed how like they'll flip over on their back and you'll see their little legs like quivering back and forth, and the insect is like shaking, and sometimes that lasts for a really long time. Well, that's part of the effects that these organophosphates have on nerves, and they work on the insects, but if they're consumed by a human, something similar happens. So I wanted to show you this.
Stacey, I've heard that in certain overseas countries that organophosphate overdose is in fact the most frequent cause of overdose and fatalities in younger people. Have you heard that?
Yeah, India is one of the countries where you end up seeing a lot of these organophosphate overdoses because the organophosphates aren't banned. And so they actually have quite a problem with suicidal ingestions of organophosphates. So yeah, definitely much more common in other countries.
Stacey, our dear friend, Crystal Phillip, who gave us a really awesome lecture a while back, has an awesome case of organophosphate poisoning in a young child. So you're absolutely right. They see that a lot in that part of the world.
Yeah.
Stacey, just for an update, we're 45 minutes in and we are totally cool. Talk as long as you want. We're right here for you. Okay.
All right.
Rock and roll.
So here's a little bit of a case that was a mystery, and this was a number of months back. This was a 16-year-old guy, and he developed cough and shortness of breath at an outside hospital. He also had nausea and vomiting. His flu test was negative, and he started to decompensate and develop respiratory failure. So he ended up getting intubated, placed on a ventilator, and he was transferred to Children's Medical Center. So his parents went home and they searched through his room, and this is what they found. This is vaping cartridges. And so this was the beginning of what we saw as what's called EVALI, which is E-Vaping-Associated Lung Injury. And so what's interesting about this is that if this case were to show up now, we would probably be thinking about COVID. But this was kind of at the beginning of COVID, and also sort of towards the middle of EVALI. But this is what a normal cross-section of a CT of a chest would look like. Again, the air should look black, the lungs should look black. But in EVALI, the lungs look whited out. And truth be told, I have to say, I feel like EVALI looks a lot like COVID. And part of me wonders if some of the early COVID cases were EVALI, or if some of the EVALI cases were COVID, and we just didn't know the difference. It's hard to say. I mean, we have yet to really discern what is the cause of EVALI. It seems to be mainly associated with these vaping cartridges that are sold on the black market. And the thought was that there were certain fats and oils that were depositing on the linings of the air sacs in the lungs to cause an inflammatory reaction. So when they would go down with a bronchoscope and look at the lungs, they would take a biopsy and they would see some of this fat inside the air sacs, but that was not universal across the board. And so it's hard to say that that was actually the true cause. So I don't know. I bring up the fact that I still pontificate at times if we were seeing COVID and didn't realize it. So first Q&A.
All right. We have a lot of questions from the chat so far. A lot of the students are amazed and shocked about the photos you brought on. One of our questions is, Dr. Hale, what is the craziest toxic substance you've encountered so far?
Oh boy. I would have to say, I remember strychnine is an old rat poison. And that is something that you don't really come across very often. And strychnine causes people to have what we call on our board exam seizures while awake, because it causes people to have these weird shaking movements, but they're not originating from the brain, they're coming from the spinal cord. So you don't lose consciousness like you do with seizures that originate in the brain. So the adage is seizures while awake. So someone is wide awake, but they look like they're having a seizure.
Oh, snaps. Another question that we have is, do you find drugs like K2 to be more prevalent in younger adults/teens?
Yes, absolutely. Not that I haven't seen some older adults that have gotten into it, but it comes in fancy little packages, and because it was initially legal, they were sold at gas stations and things of that sort. And actually, I was involved in a case here locally in Dallas. There's a company called the Gas Pipe, and they were actually marketing K2. And I don't know how familiar you guys are with K2. Hopefully not, but it's plant material that's little leaves, and then they spray the synthetic cannabinoid on the leaves. And what would happen was, as soon as the DEA would ban one of the chemical substances, they would skirt the drug laws and spray a different compound, albeit similar. And sometimes these compounds have similar effects, but they're not necessarily similar chemically, so the Analog Act doesn't work for them to get prosecuted. So anyway, the way that the K2 and Spice are packaged is, in fact, I think I have one. 1 second. Oh man, I can't reach it. I have a package, an empty package. Not that I smoked it myself. I have an empty package of K2, and you can see how they're just fun looking and something that would be attractive to a younger group.
All right. Wow, I can't believe you have that casually in your house.
Well, I have my own Tox museum, and I wish you could see it, but I can't move my computer. But I collect a lot of antique drug bottles and things that we've come across over the years and saved them.
So speaking about, younger adults/teens with drugs, if a minor reveals something to a physician, say that they are taking an illegal substance, are physicians obligated to keep it private from the parents?
Wow, that's a great question. And I honestly don't know the answer to that. What do you think, Dr. Fowler or Gil?
I'm sorry. You're faced with, well, let me start with parents have the right to consent for their children. So the short answer is probably yes. That's the short answer. it gets more complex than that when you find out, why is the kid doing drugs? What's his problem? What are the issues and so forth? But the long and the short of it is that we are usually challenged by time. And so our ability to help things generally for kids starts with their parents by and large.
Unless if a child, kids can self-present to the hospital sometimes for these. And if they self-present, then that is the time for us to, you're not absolutely required to let the parents know about this if it's not a medical emergency or their life is not at a threat. But yeah, if the parents are there with them and they're a minor, they're going to have to know, especially if there's a medical emergency.
My approach to that a lot of times is, in the emergency department, we can be really busy, and trying to have a conversation with somebody and trying to convince them that it's in their best interest to get their parents involved may cause them to lose some trust in you as a physician as you're managing them medically. A lot of times we work with social workers and other kinds of counselors and psychiatry in the emergency department that may help us, approach that person with the fact that, this is an issue, involve your parents, and hopefully they'll come around and understand that they need some help.
Mm-hmm. So speaking of, they possibly needing help, what kind of support, like say support groups, therapists, etc., do you refer to your patients who overdose on illicit drugs? Or is it up to the patient to find that support?
Well, if they are sick enough, then they're going to get admitted to the hospital. And while they're admitted in the hospital, because they overdosed, if it was a suicidal overdose, then the pediatricians would be consulting psychiatry. And if they feel like the person is depressed enough that they need to go to an inpatient facility, part of their treatment is going to be substance abuse issues if the person is abusing substances. If it's just an isolated overdose on, say, like, a bottle of aspirin or something like that, then probably most of their treatment is going to be geared towards dealing with the depression or whatever caused them to overdose in the first place. Now, a lot of times in pediatric facilities, we get what we call exploratory ingestion, which are little kids that happen to get into a drug or a chemical or something like that. And they're not obviously suicidal, they're just exploring. And in that circumstance, it requires a social work consult and often a referral to Child Protective Services to make sure that the child is in a safe home.
Gotcha. We had another question from a student who asked, what safety procedures do you have to follow when encountering a toxic material brought in by a patient?
If they're bringing it in, like if they're, I guess it kind of depends on the chemical. Most of the time, like when someone has an exposure to a dangerous chemical, it's because they had some type of industrial accident or spilled it on themselves at the factory. And a lot of industries have in place a lot of procedures where the person will get decontaminated before they ever come to the emergency department. But if you ever come to Parkland, you will see that outside of our emergency department in the ambulance bay is the whole plumbing system, and it has curtains. So if there was ever a mass casualty incident where folks were covered in some kind of chemical, they would actually be decontaminated outside of the hospital. Now, if it's an isolated patient, we have an indoor facility where that would happen. But I haven't had very often a situation where someone hands me a dangerous chemical, but it is not uncommon for us to encounter patients that have illicit drugs on them. And in that situation, we would hand over those kinds of substances to our Parkland Police Department.
You know, if anything, we try to keep these patients out of our department. If they have a hazardous materials on them, the fire department with their hazmat team and the decon team, et cetera, will do everything they can to get the patient as clean as possible before they even hit the doors and expose to other patients and staff.
All right, we have so many good questions flying in. Another question that we have is it difficult to distinguish between psychosis and drug use?
Oh, absolutely. And the person that can develop that art is a very special physician. But I will tell you that one of the terms of the trade, or a bread and butter term in medical toxicology, is a word called toxidrome. Toxidrome is the words toxic and syndrome mashed together into one. So if you remember from English class in school, a word that is smashed together is a portmanteau. Portmanteau is a French word for those little suitcases that you would fold over and put together. So the same thing happens in the English language. If you mash two words together, it's a portmanteau. That's your English lesson for the day, by the way, guys. So toxidrome is a portmanteau of toxic and syndrome. And one of the things that medical toxicologists excel at is distinguishing the different toxidromes from one to the next. And there are a number of them, but it is the constellation of signs and symptoms that are unique to a certain substance. So for example, heroin, which is an opioid, there is an opioid toxidrome. And so pinpoint pupils, central nervous system depression, and respiratory depression. So unconscious and barely breathing. That's what the opioid toxidrome looks like. Sympathomimetic is like a stimulant toxidrome, like from cocaine or meth, where you're agitated and your heart rate is high and your blood pressure is high and you're sweaty, you're acting crazy. And so the thing about psychosis is that you can actually be pretty calm, but still hallucinating or having a delusion. And so the difference is that we look for other physical findings that are worrisome, like the blood pressure and the heart rate, that are likely going to be absent in someone who actually just has psychosis from a psychiatric reason.
Gotcha. And then going off of that, we have a question. Have you ever suspected a patient abusing substances, but they refuse to admit what happened? If so, how do you handle that situation?
Yeah, that is a pretty common thing to have people say that they didn't use anything. Of course, the most common is if you ask someone how much alcohol they drank, and the answer is always 2 beers. Okay, but the same thing can happen with other substances where they deny it completely. But again, we're pretty good at recognizing a lot of the different toxidromes, and sometimes they can be confirmed on our urine drug screen, and then you can approach the patient. The other thing that we have is something called the PMP, which is the Physician Monitoring Program. And it is, we all have the ability as physicians, those of us that have DEA numbers, to log on to a government database and see all of the prescriptions. And I'm talking about controlled substances, not like your blood pressure medication. And so there are some times when what are called drug-seeking patients, people that are specifically looking for certain kinds of narcotics, will come in and they'll say, oh, I hurt my back and I need, fill in your whatever, oxycodone. And you can go to this database and you can see whether they've never had an oxycodone prescription or if they have like 50. And when that happens, you can go back and say, listen, I can see that you have other physicians that are prescribing this medication, and hopefully use it as a springboard for discussion.
Gotcha. Okay, 2 more questions and then we can move on to the rest of the presentation. A student asked, how do you quantify the amount of toxins ingested, or do do you at all? Is it purely based on what patients tell you? Do you take serum samples and run a scan? How involved are you in this process?
Well, I love that question because that will tie us in nicely to the next part of the discussion in some ways. But if someone comes into the ER and they overdosed on, say, a bottle of Tylenol, well, the first thing that we look for is, did the paramedics bring in that bottle? And can we, or if a prescription medication that they overdosed on, and we look for a pill count. And a lot of times I will just dump the whole entire prescription out on a paper towel in the ER to count the number of pills. Because, sometimes you have to know that if someone is upset enough to overdose on something, they may not necessarily remember how much they took, and they may think they may overstate it or understate it. So we do ask a lot of our EMS providers, if they're able to bring in the prescription bottle or the over-the-counter aspirin bottle or whatever, and we can get an estimate of that. Now, the question is, when you send a blood level of a drug, what does that number mean? And therein lies one of the quintessential questions that people hire me for as a medical toxicologist and as a forensic toxicologist. Essentially, I think that there are a lot of folks out there, including all the lawyers that I work with, that think that when you overdose on something, that you come into the ER and we send a blood level of cocaine, or we send a blood level of heroin, or we send a blood level of oxycodone or meth. That is absolutely not the case. First of all, those numbers don't mean anything because one level in one person can have a different effect in another person. And so this is where the toxidrome comes in. This is what's so important, is we treat the patient, not a number. So if someone overdosed on heroin and they come into the ER and they're barely breathing and they're unconscious, I don't sit there and say, oh my, let me get a heroin level. First of all, I would never be able to get one in a timely fashion, and the patient would die if by the time I got it back. And if I had a magic machine at the bedside to check that heroin level, let's just say, I wouldn't know what that number means. I couldn't even begin to give you a number. So the point is that if that patient is unconscious and barely breathing, they need Narcan. So we don't ever send a heroin level. And the thing is because heroin is an illicit substance, I don't have any way, nor do they have any concept how much they injected or snorted. And, drug dealers don't have a very good quality control department. So we don't really know what dose they're getting. So again, that's where we look for the toxidrome. Again, the adage is treat the patient, not the number. And that's a patient that we would administer Narcan to. There are only a handful of substances that we actually send levels on in the healthcare setting. And that would be aspirin, Tylenol, lithium, and some of the anti-epileptics, the seizure medications, and some of the antibiotic levels, but that's done more in the hospital setting. So
Stacey, you're telling me that after all these years, that actually at the bedside with some of these patients that have a toxicologic issue, that it falls to physician judgment?
Absolutely. And that is when we go into this next section and talk about some of these interesting cases, I end up having to teach a lot of lawyers and juries and judges about how we don't make decisions based on numbers in the healthcare setting. And when I tell lawyers that, it's like telling them there's no such thing as Santa Claus. They just cannot handle it because everybody wants to think that as a toxicologist, we are hanging our hat on a number. And that is absolutely not the way it plays out in real life.
Well, Stacey, we are 1 hour and 5 minutes in. I want everybody in chat to say, keep going, Dr. Hale, if that's what you want. But we're going to move to section number 2 now. We just had 200 people put "keep going, Dr. Hale." So Stacey, you've got
I hope
600.
everybody wants me to keep going because the next part is.
I wish you could see it, Stacey. You've got 600 people saying "keep going." So you've got 630 people listening to your every word. So please keep going.
All right. Well, so this next part is my favorite part. And so I think I've just made the point that I do work as an emergency physician on the front lines and as a medical toxicologist in the healthcare setting. But I said at the beginning of the presentation that I work part-time in the healthcare setting, and that's because of this part that I do. I started an expert witness business about 15 years ago. And this is where I work with attorneys and I work with FBI and Department of Homeland Security and DEA and local law enforcement on a whole host of different cases. So over here on the left, this was me on the news down in Houston when I was actually testifying in court with the MD Anderson doctor that poisoned her colleague. I'll talk about that in a minute. And this was in a trial down in Houston. The center photo is me at the Drug Enforcement Administration, so the DEA, the training center in Quantico, Virginia. And this is, Quantico is a military base right outside of Washington, DC. And this is where all of our FBI and DEA agents get trained. And I don't know if you've ever seen, like in movies or whatever, but there's something called Hogan's Alley. And this is where it's actually like a fake city with suburbs and pharmacies and little stores. And that's where the FBI train. So I went there to help train the DEA. And down here, I'm giving a press conference at a DOJ press conference, which is the Department of Justice. And then here I am, I had to put on the DEA police vest just to feel important. And then up here on the right, this is me giving lectures up in Wyoming. Actually, these two pictures on the right, this is with the governor of Wyoming. And his family, actually, they're the ones that owned all the land that became what is Jackson Hole. And then this was the U.S. Attorney of Wyoming at the time. And so down here were the folks that I was training. These are the Wyoming cowboy cops. And there they are with their, they're exactly what you would picture as a Wyoming cowboy cop. And I felt left out because I didn't have my hat, my boots, or my 45 on my hip that day. But these are the kinds of experiences that I get to have that are super cool. So just to put things in perspective, ER doctors may make $150 to $350 an hour. But as an expert witness, I actually charge $700 an hour doing expert witnessing and forensic work. And most of that is actually sitting at home. So I even charge that per hour if I'm sitting on an airplane. So that adds about $250,000 to $350,000 to my income, which is not bad for a side job. So I say that just because I get asked a lot of questions about, when you guys are deciding what you want to do with your life, and your compensation is part of that decision. I just wanted to throw that out there so that you have an idea. And when you're an expert witness, you're not selling your opinion, you are selling your time. And so whether that time is spent on the witness stand getting grilled or in a deposition with a contentious plaintiff's lawyer on a malpractice case, or if you're just sitting on an airplane flying to Hawaii watching Netflix, you are charging $700 an hour. So I recently had a trial in Honolulu, and that flight is about 7 to 8 hours out and 7 to 8 hours back. So that's about a $10,000 paycheck just sitting on the airplane. So that's just to help you guys get a sense of whatever kind of physician you end up being. You can do expert work on the side because there are always medical malpractice cases, or you may develop a niche like in child abuse cases. A lot of trauma surgeons sometimes talk about injury patterns. So not that you have to do as much of this as I do, but this is something that a number of physicians do just on the side to supplement their income. And it's also really interesting and it's good experience. So I have had cases all over the United States. And so I've colored everywhere where I have actually had a case. And I had to also color in Manchester, England, because I had a case in England and it was an inquest for the Crown Coroner. And that was super interesting. So it is a pretty national practice, and I do end up having to travel quite a bit. So now is time for the forensic files of Dr. Stacey Hale. And these are some of the cases that I've worked on that I think you might find interesting. So this is the state of Texas versus Ana Gonzalez Angulo. And this is a case that happened down in Houston at the MD Anderson Cancer Center. And this is Dr. Ana Gonzalez Angulo. She was a renowned breast cancer doctor. So she was an oncologist. And this was her colleague. He was a specialist in head and neck cancers. And so he was also, he still is an oncologist, and his name is Blumenschein. So this is the story of the love triangle of doom. So here's Dr. Blumenschein, and he was in a common law marriage with this lady, Yvette, and she was a drug rep, and so that's how she knew him. And then over here is Dr. Ana Gonzalez Angulo. So Dr. Blumenschein and Dr. Angulo had largely a professional relationship, but she had a bit of a fatal attraction for him. And so I would say that their relationship probably had crossed the line a couple times, but all was fair in love and war until the day that Dr. Blumenschein and Yvette decided that they wanted to have a baby. So they were undergoing some fertility treatments to have a baby, and that just kind of set Dr. Angulo over the edge. And so the first thing that she did was she lived in this like townhouse complex, and she beat her own self up outside by her mailboxes, and then called the police, and they were like, oh, let us take you to the hospital. And she's like, no, don't take me to the hospital. But call George Blumenschein and tell him this has happened to me. And then there were some letters that she was sending. Well, so what happened was he went to a medical conference out in San Diego, and he was there, and then he flew back with a colleague on the plane, came home, had dinner with Yvette. They shared a bottle of wine. And then the next morning he got up at 7 and he went over to Dr. Angulo's house, where she served him this Colombian coffee. Now, she was from Colombia, so she's like, try this coffee. And his first reaction was, this coffee is way too sweet. And she's like, oh, just drink it anyway, and I'll get you another cup in a minute. So he drinks the coffee, they go into work, they're working in the laboratory for a while, and as time goes on, he starts feeling strange. And then they go to dinner that night with colleagues, and their colleagues are all doctors. And they thought that he was having a stroke by the fact that his speech was slurred and he was falling all over the place. And he wasn't drinking any alcohol at dinner. So they were like, well, he needs to go to the hospital if he's, we think he's having a stroke. So they took him to MD Anderson. And well, I should say, Dr. Angulo said she was going to take him to the ER at MD Anderson, but she took him home instead. And that's when Yvette found out, and she's like, you're taking him to the ER and I will meet you there. So they go to the ER and they can't figure out what's wrong with him. They do every test under the sun and no one can figure it out. And time is passing and time is passing. And it wasn't until in the microbiology lab they looked at his urine under the microscope and they identified what were calcium oxalate monohydrate crystals. So this medical mystery suddenly took a turn that made them have to call the police. So what do you think it is? Antifreeze. Antifreeze, which, you know, we all recognize.
So Stacey, we're not supposed to have calcium oxalate crystals in our urine?
Well, there are only a handful of conditions where that can happen. But
okay.
For example, calcium oxalate crystals can be in people that have some mineral metabolism issues, and so they are prone to kidney stones. But what was happening with Dr. Blumenschein was he was having renal failure. He was having acidosis, meaning that his blood was very acid compared to normal. He was having double vision. And that's because these crystals don't just deposit in the kidney where they find their way in the urine. They deposit all over the body, and they deposit in a certain part of the brain that was causing double vision. So when you put all of it together, it's not just a mineral metabolism issue causing kidney stones. And that was part of the exercise that we did in the Poison Center. I had all of the students that were working with me on this case. I assigned them all of the different findings that Dr. Blumenschein had. And I said, please come up with any other condition that you can find that would explain these findings. And there's nothing else. There's nothing else.
And then also might be readily at hand if someone wanted to commit murder or to hurt someone. They'd have to be readily at hand.
Well, and that's an important point, Dr. Fowler, because antifreeze is something that is found in a lot of people's garages. Probably not in Texas until last week, maybe. But the thing about antifreeze is a lot of bittering agents are added and coloring agents are added. So you can see here where it's typically like a bright fluorescent green, and then they add stuff to it so that it tastes really bitter in case, you know, the mechanic reaches over for his drink and instead accidentally drinks it and it's antifreeze and they can spit it out, or so that your pets aren't licking it off the garage floor or something.
So Stacey, I don't sip on antifreeze by and large. Is it sweet if you taste it? We just got a question on that.
Okay, so that is the greatest question, okay, because that is the point. So because both of these folks were researchers at MD Anderson and they worked in a laboratory, Dr. Angulo had access to laboratory grade ethylene glycol. So antifreeze, like I said, contains other things besides ethylene glycol, which is the main ingredient. They have bittering agents. But if you're using ethylene glycol as a solvent in a laboratory setting, pure ethylene glycol is sweet. So that's why that Colombian coffee that he was drinking was so sweet. And that's why, because this case made international headlines, the headlines said he liked his coffee black because the fact is that this coffee was way too sweet. So that's how we solved this. The crystals in the urine, because I will tell you that obviously Dr. Angulo did not say that she gave him ethylene glycol. And so by the time they actually decided to order an ethylene glycol level, it was negative because ethylene glycol metabolizes off because it's an alcohol, just like alcohol that you would drink from a bar metabolizes off. And so that was one of the defense points, or at least they thought it was going to be, that he wasn't poisoned with ethylene glycol because his level was negative. And so
it turns into formic acid, is that right? And that can be detected?
Well, it turns into it turns into glycolic acid, glyoxylic acid, and oxalic acid, which is where the calcium oxalate comes from. Calcium binds with that oxalic acid to make those crystals. Formic acid is from methanol. When methanol gets metabolized.
I'm sorry. You're right.
So the point here And this was the point that I made in the courtroom, was that just because the ethylene glycol level was negative does not mean that he was not poisoned with ethylene glycol. So that's what I taught the jury, that's what I taught the judge, and she was found guilty and sentenced to 10 years in prison. So he did not die, so this was an attempted murder case. Technically, it is assault with a deadly weapon, with the deadly weapon being ethylene glycol. And so he's still alive, he has some renal damage, and she got 10 years in prison. But this was a case that was popularized in the media. And so I have starred on the show Vengeance Killer Coworkers, and that's on the CNN sister channel HLN, and as well as Snapped, which is where women snap and attempt murder or commit murder. So this next case is the murder on the lake, and this is up in Coeur d'Alene, Idaho. This was a view from my hotel room, and this is a case where this lady, Lori Eisenberg, did something to her husband, Larry Eisenberg. And so what happened was they went out on the boat during the winter on Lake Coeur d'Alene, and he never came back, and he was found 2 weeks later after he floated ashore. And so as the story goes, she was working for a charity in Idaho that houses underprivileged people, and she embezzled like $600,000 from this charity, and they provide government housing, and they figured it out. And so they I guess put her on administrative leave while they were investigating this. Well, she realized that her husband was going to divorce her if he found out that she had embezzled all these funds. So she had to come up with a plan that he would not find out. And that plan, I guess, is a little bit extreme. Murdering somebody so that they don't find out what you did is on the extreme side. And to explain what she did, it just takes a minute for me to explain that down in South America, there is something called devil's breath. And this is poisoning with an agent called scopolamine. And a lot of people thought that this was an urban myth, but this is written up in the medical literature. And scopolamine, which is also known as burundanga, is something that comes from the plant species Hyoscyamus albus and Datura stramonium. So these are these plants that grow in South America, and here's a picture of them. So scopolamine actually makes you lose your free will. And so criminals would poison individuals with this scopolamine and then lead them to ATM machines and then have them take out a bunch of money and hand it over. And so there are a number of different stories where this has happened in the 1950s. And what is actually happening from a toxicology standpoint is anticholinergic delirium. So when we talked about the toxidromes earlier, this would be the anticholinergic toxidrome. And they develop this lack of free will. And so they're awake, but nobody's home, and you can lead them into these situations. So what happened in this case was not scopolamine, but something a lot more accessible. She used Benadryl, and she used a lot of Benadryl, and she put it in one of these kinds of smoothie drinks that's already gritty by nature so that it would be undetected. And then he developed anticholinergic delirium, was able to be led out onto the boat. And, because you wouldn't take a boat out on Lake Coeur d'Alene in the wintertime because, it's too cold, and they winterize the boat. So that's why a lot of the neighbors thought it was strange that the boat was, that she was taking the boat out. And then whether he fell overboard or she pushed him overboard is hard to say. But nevertheless, there were a lot of other things in the evidence that I had to review that helped to solve this crime. So now we're going to talk a little bit about the opioid epidemic. And these are faces of the opioid epidemic from the People magazine. And the blonde girl on the upper left is a daughter of a person that I know in Florida who died 1 week before her high school graduation. And her boyfriend actually injected her with heroin and she died. So the opioid epidemic has been a problem for a number of years, but it's switched from the junkies of the 1980s in the gutter in New York City that were shooting up heroin. It's become a lot more accessible because it's run like a pizza delivery service from folks from the Mexican drug cartels in the suburbs. So it's become a suburb problem. But this is a case I had recently where it was not heroin, but it was fentanyl. And this is the United States of America versus Aaron Shamo. And this was a Mormon kid from Salt Lake City, and he was an Eagle Scout. And he was running a global fentanyl empire. So what would happen would be he would order fentanyl from China off the internet. And basically he lived in this house in Little Cottonwood Canyon outside of Salt Lake City. If any of you guys ever ski up there in Park City or Salt Lake City, this is close to there. This machine is a pill press, and he was taking the fentanyl, he was pressing it into a tablet that was like a fake oxycodone, and then selling it on the dark web. So when the FBI raided his home, this is just one drawer of cash that they found in his house. It was millions of dollars of cash. So he would sell these fake or counterfeit oxycodone pills on the internet and on the dark web, and he would get Bitcoin in return and then go to a Bitcoin exchange and turn it in for cash, and he housed all the cash at his house.
Hey, so, Stacey, for the benefit of the group, what is fentanyl as compared to heroin and so forth?
So fentanyl is a chemical that is an opioid, and whereas heroin is about 1.5 to 2.5 times on a potency scale, fentanyl is about 100 times more potent. And so individuals that are even tolerant to heroin or tolerant to other opioids will fall rapidly into loss of consciousness and will stop breathing very quickly. And so this was a global enterprise, and it turns out that the US Postal Service frowns upon you mailing drugs around the world, and fentanyl is one of those. So this individual was found guilty, and he will receive life in prison.
A student asked, on the topic of opioids, Oregon has a campaign called Reverse Overdose Oregon. This campaign seeks to encourage people to become trained in administering Narcan, as well as encouraging employers to have this nearby. In your opinion, do you think campaigns like these work? Should all employers be required to be trained on how to administer Narcan? What are your thoughts?
I think that if you have the ability to save a life with Narcan, then by all means, I am for that. And you know, there are some caveats to administering Narcan, and I think anyone who, you know, if you're a family that has a son or a daughter or a family member that has opioid addiction and you want to keep Narcan on hand, it is probably a good idea to have some level of training to understand how to do it, but also that when you administer Narcan, you can risk putting somebody on withdrawal. Now, opioid withdrawal is not life-threatening, but it's very uncomfortable. And if you can't get somebody into a place where they're safe, they may choose to go shoot up a much larger dose than they otherwise would to overcome those withdrawal feelings. And then that could be deadly. The other thing is if somebody mixes, say, for example, heroin and Xanax. Xanax is not reversed by Narcan. In fact, nothing else is reversed by Narcan except for opioids. And so you may reverse the opioid side of things, but not if someone is unconscious by another central nervous system depressant. And if you put somebody into withdrawal, part of opioid withdrawal is vomiting. So if they're unconscious and you can't reverse the unconsciousness from another sedative, but they're withdrawing from the withdrawal of the opioid, you now have an unconscious vomiting patient, which can be a bit of a nightmare. Now, of course, if you don't administer Narcan, the risk of death is a pretty poor prognosis. So I think that just being a little bit educated about some of the caveats of administering Narcan is worthwhile.
So Stacey, do you have like an IQ of 1,000? How have you been able to learn all this toxicology stuff? To me, as a physician, for a long time, it's so complicated. I mean, how do you remember all this stuff?
Well, you know, the fellowship is 2 years, and to teach is to learn. And so you get a lot of redundancy in your fellowship, and you get a lot of redundancy when you're treating these sorts of patients. And then when you end up developing a certain niche, you develop an expertise in this area. And again, to teach is to learn.
Going off of Dr. Fowler's question, a lot of our students are so inspired by you and want to be future toxicologists. Do you have any tips on, what education route they should go through, or what should they really focus on in school if they want to be future toxicologists?
I would say I was a chemistry major, and I loved chemistry. I realized that chemistry is not for everybody, and including my own kids, which is why they want to be rock stars instead. But just the pre-med track is certainly all you would necessarily need. Chemistry is a little bit of the icing on the cake. And like I said, most toxicologists go into emergency medicine because a lot of this is acute medicine. But you can do a medical toxicology fellowship after internal medicine or pediatrics. But you cannot just go straight from medical school into medical toxicology. You do have to do a residency. And the most common is emergency medicine, followed by the 2-year fellowship in medical toxicology. And a lot of folks are like, oh, I can't be a toxicologist because I'm not smart enough to be a toxicologist. The point is, everyone likes to say we're smart because we did the toxicology fellowship. And when you do a medical toxicology fellowship, people like to come and ask you a lot of questions when you're working in the ER because you have really honed your skills in pharmacology and as well as learning those toxidromes. So yeah, we're smart because we did the fellowship.
So Stacey, these are pre-health kids that are listening to you tonight. There's still almost 600 listening. We get a lot of moaning and complaining about organic chemistry as one of the things they have to take to get into school. So can you reflect back on your organic chemistry years and how this factors into your work as a toxicologist?
Well, I think it just gives you a nice basement of knowledge and a fund of knowledge. On the tox boards, there are some chemical structures, but it's not at all like organic chemistry where you have to do all of those redox equations and draw out the hydrocarbons or the cyclic hydrocarbons and all of that. It's not any kind of chemical synthesis. It's more like recognizing the general structure of an amphetamine or the general structure of, say, like a benzene ring or whatever, and knowing what kind of clinical effects will come from those and having a general sense of what those structures are. But the day-to-day practice really doesn't have much to do with being good at organic chemistry.
Thank you. Rachel?
So to be in the field of toxicology, do you have to be a physician? Can you be a PA? Can you be a nurse? Can you be a nurse practitioner?
No, to be a medical toxicologist, you have to be a physician because it is that 2-year fellowship. Now, with that said, there are a number of pharmacists that will do this toxicology fellowship as a PharmD, and they don't necessarily take care of patients, but they end up being involved in a lot of the inner workings of the poison center.
Gotcha. So a lot of students are fascinated that you're both an EM doctor and also a toxicologist. So how do you split your time between those? Is it like working 2 jobs, or are these areas really well blended together?
Well, that's the best part is, no matter what kind of medicine you go into, there is going to come a time in your career where you're a little bit burned out by it. And so I have sort of designed and fashioned this perfect career where that's not going to happen, because I work just enough shifts in the emergency department to keep my skills up and to love it and not to dread it. And then every so many weeks I'm on call for the poison center, which is a 24/7 thing for an entire week. And that's clinical work and academic work. And it all gets smushed into this 1 week. And then it's only every 2 to 3 months or so. And then I fill in all the in-between time with doing expert witnessing.
Oh yeah, a lot of our students are very thankful that you are very transparent on your career and especially on your pay. I just wanted to convey that thanks. Going back to your hours and whatnot, what kind of hours did you work with at the beginning of your career, and how long did it take until you were just basically doing 45 hours in the ER?
So when you're in residency, you don't really have the choice of choosing how much or as little as you work. And so once I got out of residency and I was doing my fellowship, the thing about being in your fellowship is you still work shifts in the ER. And so I worked about 4 shifts a month in the emergency department while I was doing the fellowship. And then once I got out of fellowship, that was when I started birthing babies. And so I decided to be part-time, and that was actually a blessing in disguise, because as a full-time faculty, you weren't really, they didn't really want you doing a lot of side work like that. So as a half-time faculty, that's how I ended up getting into the expert business, was because I was the person that was not full-time. All the cases were flowing to me. And then once I realized how much I loved it and how it was a nice boost to my income, and also, when you have small children, then you can work from home for a good part of the time. It was the perfect fit for me, and it's intellectually stimulating. So it was something that I have actually never worked full-time clinically in 20-something years. I've been mostly half-time from the very beginning.
Gotcha. How much free time would you say that you have? Can you ever take a long vacation, or is it limited because of all the hats that you have?
It is not limited. We actually have lots of fun vacations. And the thing is with my husband being a lawyer, sometimes he has to do work on vacation, and being an expert, sometimes I have to do a little work on vacation. I've gotten really good at planning things, and because of the fact that trial settings are made months in advance, I can put that on my calendar. Because our ER shift schedule is made, a couple months in advance, I'm able to design it exactly like I want. That's the thing about emergency medicine, is that you're not on call the way that you're on call for other specialties. So I don't get called in from home to go to the ER. Now, we do have call as medical toxicologists, but it is not as extensive as like if you're an OB-GYN or something. So yes, we are kind of mountain people. We like to go skiing a lot, and all my kids are pretty good, and we like hiking and a lot of outdoor stuff. Actually, right before the snowstorm, my husband and I took a husband-wife trip to Miami, and I was on South Beach 24 hours before I was ice skating on my street out here.
So Stacey, you don't work really, excuse me, a full-time job. You have several jobs that you do that makes your income, supports your family along with your husband and so forth. you've chosen not to do the same thing 40 or 50 hours a week, and instead to do a consulting business for, say, about half of your time, which gives you freedom. What is the advice that you would give to the students that are listening tonight? There's still over 500 online. Is consulting a possibility for them, or what would you say to them?
Well, I would encourage anybody that goes into the field of medicine to at least do one legal case in their lifetime, just to get a sense of what it's like. And so whether you go into OB-GYN, whether you go into surgery, whether you go into pediatrics, there are medical malpractice cases that exist. Like I said earlier, child abuse cases, things of that sort. And it's another way that you can use your services for good and the good of the community and others. And there are some physicians that enjoy it so much that they do a little bit more of it. And you'd be surprised how many legal cases there are that involve medical related questions and topics. And it just so happens that toxicology, because it involves all the drunk driving cases, anything to do with alcohol, workplace, marijuana, chemical exposures, any medical malpractice case involving drugs in any field, all the drug crime, all the murder cases with poisons, there just happens to be a lot more in toxicology. But any field of medicine, you can do cases from time to time.
Well, Stacey Hale, what a wonderful presentation tonight. This has been remarkable. I would like to first ask that everybody, all of the 510 still online, please put "thank you, Dr. Hale" into chat so that she can see that and all the little hearts that are coming over. Stacey, what a remarkable discussion. This was just wonderful. It gives opportunity for consideration for some of us to get into consulting careers, though you had the courage to do it early and to be able to offer your expertise to a world that needed your intelligence and your focus. Rachel, do we have any last couple of slides here? Or
yes, we have one more slide. So could you go to the next slide, please? All right, everyone, assessment number 38 will be opening in a couple of minutes. This assessment is due next week, March 2nd at 6:59 p.m. Central Standard Time. Please remember we're in Central Standard Time. All you have to do is enter in the PIN, which we will email out, post on our Instagram, and also post on our website. Please enter in the PIN with the dashes into Find My Assessment, and then enter in the password, Hale, no caps, no spaces, and then you should get access to the assessment. Again, these assessments aren't hard. They're only about 10 multiple choice questions, and you have about a week. Remember to download those certificates as proof of attendance.
So Stacey Hale, thank you so much for joining us tonight. We've had over 45,000 people from 28 nations and over 950 universities that have joined us on virtual shadowing. And for you to be here tonight and to offer your expertise and your amazing commitment to humanity is just wonderful. Stacey, just to let you know that this episode tonight will make a difference. We typically have about 5,000 pre-health people watch these episodes. Each one of them will go on to see 100,000 patients in their lifetime. 5,000 times 100,000 is 500 million. So Stacey, tonight you've touched 500 million lives.
That's pretty amazing.
And we hope that that's means as much for you as it does for us.
Awesome.
So anyway, thank you everybody, and all 45,000 of you out there. We'll be here next week. We've got some great sessions coming up. We want to thank Dr. Hale for what a remarkable presentation this was. I'm going to make sure I don't get into trouble, Stacey. All right, everybody. So thank you. We want to thank all of you for coming. Bless you, stay warm, and we will talk to you next Tuesday night. And on behalf of Virtual Shadowing, have a great evening. Good night.